Hi guys, welcome back to my channel. I am Nurse Babe Britt, and in today's video, I am going to discuss a question I received in my previous video asking me to explain the difference between working in the ICU as an RN versus working in the ICU as a nurse practitioner. For those of you who are new to my channel, first, welcome. I am a third-year nurse practitioner student. I will be graduating with my DNP, that's Doctor of Nursing Practice, and my specialty track is Adult Gerontology Acute Care. So I am going to answer this question from my personal experience as an experienced RN and a nurse practitioner student who has completed clinical rotations in the critical care setting. So first, I will say, if you haven't already, please go back and watch my previous video. I gave you guys a very thorough life update of what things have been like thus far in my third year of the nurse practitioner program. And without further ado, let's get into the question. So I am going to answer this by just first explaining the flow of working in ICU as an RN, and then I'll compare that and contrast it from working in ICU as a nurse practitioner. So starting my shift, working in the ICU, I come in, I get my assignment, I get report on my patient from whoever had the patient overnight. During report, you're getting, a brief medical history, why this patient was admitted, and then you go head to toe system-wise in discussing everything in that system, discussing assessments, if the patient has good pulses or no pulses, are they alert and oriented ×4, or if they are a little bit confused, are they sedated? You go over drips, medication infusions, labs, anything that was out of the normal, anything that was replaced, if any blood products were given, any skin assessment, like if the patient has a wound or something like that, any IV access, any chest tubes, all of those things are things that you're discussing in report as a RN. Then after you get report, you go in, and usually, first of all, report should be at the bedside, right? But usually after you finish getting report, now you are looking at the pumps, the IV pumps, to make sure that what's ordered is what is infusing. That's very important. And if you don't do that, please do that, because that's when a lot of medication errors are caught, is when you're doing that bedside report and bedside handoff. So highly recommended, because I have seen several things be caught during that process. So after you verify that, let's say your patient is on some type of mechanical support, you want to take a look at the site, make sure it looks good. You want to make sure they have pulses. If they have something maybe in that growing area, you want to make sure they're still getting flow to that extremity. So you want to make sure you're checking pulses, all of those things. Then after that, you start your shift, right? So what I usually do is I look up my patient, because of course I've gotten a report, but sometimes things get missed in report. So I like to read the provider's note, and that way I have a more thorough picture of what's going on with that patient and why they're here and what the plan is. Then I look up my medications that are coming up that are due, because if the shift starts at 7, then I should probably be finished getting report by 7:30-ish. It just depends. And so I'm looking up medications that are due between the 8 o'clock and 9 o'clock hour. So by the time I go in there and do all of my 8 o'clock things, I can give 8 o'clock meds and I can give 9 o'clock meds. I usually like to pull my meds first, and then I assess my patient and do all the things, empty drains, get numbers if they have thermal dilution, get my cardiac output, things like that. That's very CV-ICU specific, so just tailor it to whatever specialty you are in, if it's neuro and things like that. Versus as a nurse practitioner, I'm going to take it a step back and start the shift. So as a nurse practitioner, you get signed out. It's pretty much the same as getting report. It's more comprehensive, I would say, because you're going through some of those things as far as assessment, but you're also going through a lot of the medical diagnoses. What are we doing? What is the plan? Have we talked to family? Do we need to talk to family? What is the surgeon wanting to be done? Or what is the attending wanting to be done in the ICU? All of the different things. And once you finish sign out, I would usually just, during my clinical rotations, I would usually take the time to look up my patient. I would go ahead and order labs for the shift. I would go ahead and order the chest x-ray if they need a morning x-ray for the shift. I would go ahead and put whatever orders I need to put in that apply to that patient. I look at the trend of vital signs. I look at the trend of urine output, drain output. If they have any mechanical support devices, I look at the trend for those numbers. So I look at labs and I look at the trend. All of those things are what I do before I even go see the patient. And then once I finish looking up all my patients, usually I jot down little notes that I want to address or something I want to verify when I go in the room or talk to the nurse about. I'll jot it down. So that way now, as I am rounding on the patients that we have, I usually like to talk to the nurse and go over the goals and plans for the shift. Also, verify what drips are infusing on that patient, what mechanical support devices they're on, and what are the numbers for those, and things of that nature. Once you go over the goal for the shift and plan of care, you kind of just touch base here and there as needed for the rest of the day. And then once, like, let's say you put in an x-ray, once those images are back, or let's say you put in for labs, once those results have resulted, then it is your job to follow up on that. So it's not just ordering all these things and expecting the nurse to tell you, hey this and hey that. It is your job to follow up, and that is something they'll actually really like teach you a lot in nurse practitioner school, but I digress. Anyway, following up on whatever orders I have placed, following up on whatever is going on with that patient. And let's say the patient has a worsening chest x-ray. Let's say they have a pneumothorax, and let's say they have increased oxygen requirements. That could be an indication that they may need a chest tube. So now you get into all the procedures that are involved working in the ICU as a nurse practitioner. As an RN, you're charting all of these numbers, you're communicating any changes that you feel like are pertinent or that you just want clarification on. You're communicating that with your provider, maintaining that open communication both ways, right? But let's say the patient's on a lot of vasopressors or they're on a lot of whatever, and they don't have that much IV access. Now you may have to go in there and place a central line as a nurse practitioner. Or let's say they're on a BiPAP 100% and they're still not satting great, they're decompensating. You may have to go in there and intubate this patient. Of course, procedures vary on what you can and cannot do from institution to institution, but overall, these are all things you are trained on in the acute care nurse practitioner program. So you'll always have the skill to be able to do these things. It's just a matter of if the hospital allows that, and that just varies. But the hospital I did my clinicals at did allow nurse practitioners to intubate, to place central lines, chest tubes, etc. So these are things that I was able to see during my rotations. So I would say that as an RN, I think it can get very tasky, right? Like the provider is putting in a bunch of orders. Let's say they want labs and they want you to pull this and they want you to pull that drain and things like that. It can get very tasky. I would say as a nurse practitioner, however, once you put those orders in, you have to give the nurse time to execute some of that. And sometimes it doesn't hurt to be helpful. We have done that during my clinical rotations where, let's say a nurse is triple and they got a new admission. It doesn't hurt to help draw the first set of labs. You know, you're putting in lab orders and they're balancing, juggling all between all three patients. So it doesn't hurt to help. From what I've seen as a nurse practitioner, you can't get too caught up in doing everyone's job because you won't be able to do your job because sometimes you miss things, but it does not hurt to be helpful when you can. And it's the same thing as an RN. Like when you're helping out your colleagues, you just have to be mindful of everything that's going on with your patients because you don't want to miss something. But that's pretty much the difference between the flow. I would say as an RN throughout the rest of the shift, you're passing meds, you're getting labs, you're charting vital signs every hour, urine output and any drain output every hour. You're charting your mechanical support numbers every hour and you're troubleshooting that. You're doing your assessments, you're monitoring for changes, you're communicating any change in conditions. And then you're doing basic patient care that's not even ICU specific. Let's say you have to clean up your patient or you have to mobilize your patient. So that's what your shift is going to consist of versus a nurse practitioner. Your shift is going to consist of making sure you're keeping that bird's eye view, like I mentioned before, on everything that's going on with all of your patients. I will mention this as far as nurse to patient ratio. As an RN in ICU, your nurse to patient ratio is usually between 1 to 2 is ideal, but if it's very short, then you may have it at most 3 patients, but 1 to 2 is ideal. Versus as a nurse practitioner, you have way more patients than that. So it really just depends on the hospital, because I have heard all types of numbers, y'all. But from my experience, the most we would have is maybe 8 patients during the shift. But for the most part, we had between that 6 and 7 range, because I think they were pretty well staffed. But if you're working at a hospital that's not as well staffed and it is a larger ICU unit, then you may have 12 patients, you may have 15 patients, you may have 20 patients. So it really just depends on where you're working. I would suggest always asking those questions when you're going different places and looking at different places, like what the ratio is, because it can just vary. But those are the main differences between RN and NP. As an RN, you need to learn how to escalate and know how to escalate to your charge nurse or to your provider or attending, whatever. As a nurse practitioner, you also have to know, when do I need to call the doctor for this? When do I need to call the surgeon for that? And if you're working at a hospital where you have 24/7 in-house physician coverage, attending coverage, then I think it is very helpful, because you're not disturbing someone's sleep when you call them. But if you're working somewhere where maybe you're doing night shift and there is no in-house attending at night and you have to call them and they would have to come in for emergencies, then you just need to know what warrants a call and what may be able to wait. And that's just something I think that comes with time and experience, and also consulting your colleagues. Don't think you have to have everything figured out. Just like working as an RN, don't be afraid to ask questions, to ask senior colleagues and things like that, someone with a lot of experience with the issue at hand. So I hope that answers your question. I really think that was a great question. If you guys have any questions, please feel free to place them in the comment box below. If it's something I can't answer thoroughly in the response, then I will try to make a video to dive deeper into it. But I really enjoy your questions. Please do not forget to like and subscribe, turn your notifications on, so when I do post my next video, you will be the first to know. Again, I am Nurse Babe Britt. Thank you guys so much for watching, and I will see you next time.